Hey, it's Erin, your friendly ER educator, and today we're going to talk about arterial line basics. So when we would use an arterial line, some contraindications, basic setup, insertion, and how the nurse can help with that, and then some other nursing considerations for taking care of your patient once they have it in place. So let's take a peek at some of these course objectives. All right, so some objectives of the course. We're going to look at indications and contraindications for arterial line use. We're going to look at some basic anatomy and discuss some possible arterial catheterization sites and which ones might be a little bit better than others. We'll talk about gathering the supplies needed for an arterial line setup. We'll talk about the nurse's role in setup of an arterial line, and then we'll look at some nursing considerations that you should consider after the art line has been placed in your patient. All right, so first things first, and again, this is a very basic presentation on arterial lines. We're not going to get super in depth with this, but let's just hit on the basic stuff first and we'll just talk about what it is and what it's used for. So an arterial line is catheterization that involves inserting a catheter into a peripheral artery, which gives us the ability to do continuous hemodynamic monitoring and arterial blood sampling. So like if your patient needs frequent ABG draws. There are various anatomical sites which can be used for arterial catheterization, and again, we'll touch on which ones have specific risks and benefits associated with them. And just again, so everybody's kind of aware, this is a really invasive procedure, and so because of the risks, it's really important that the doctor and the nurse taking care of the patient has a really good understanding of anatomy, indications, contraindications, complications that can come from the arterial line. Certainly you need to discuss risks and benefits with your patient. And then it's important that we are, doing a timeout and really taking the time to do, a good sedation type procedure and making sure that our techniques are good for insertion so we minimize those risks to the patient. All right, so let's just do a little basic anatomy review here. And arterial lines can be inserted into various arteries. Typically though, our radial and femoral arteries are going to be our most popular, and a lot of that is just due to accessibility. But it's important that before we do any arterial line placement that we check for collateral circulation. So just as an example, and I've got a suggestion here or an example coming up on the next slide, but let's say we're going to do a radial artery insertion. It's important that we do something called the Allen test to check out for collateral circulation to the hand, because if it's not there, then that's not a good option for us. The last thing we want to do is potentially develop any sort of ischemic limb because we don't have good circulation while this particular artery is being used for a catheter insertion. So when we look at upper extremity options, the radial artery is typically preferred, and it's the most common catheterization site. Then it's not in the patient's groin or in their leg or whatever. It's on, the arm. It's easy to get to. It's typically preferred over other sites. You've got your ulnar artery, which can be used, but it's not great, especially if the patient has had any sort of musculoskeletal damage to the upper extremities. It's not uncommon for that ulnar artery to have some sort of blood flow disruption, so it's not a great choice. Your axillary artery is also a good option, but again, it's kind of hard to get at for the patient. It's not, position-wise, it's not the best. And then the brachial artery is also another option, but again, not best due to the lack of collateral arterial flow. And again, if you think about patient comfort, it's not a really good insertion site either. When you look at lower extremity vasculature, you've got your femoral artery, which would be like your second, probably most popular place. It's another preferred location, and it's really important that we do collateral circulation and check for that. Because we don't want to prevent, we want to prevent some lower leg ischemia. The last thing we want to do is have any sort of distal ischemia, and that, potentially that patient could lose that extremity. So we don't want that. And we'll talk about risks associated with these things too, but clots are a huge risk, and so we want to be very mindful of the size artery that we're using, where we're going, if the patient has any other comorbidities, things like peripheral artery disease or diabetes that might kind of prevent us from picking a site. So we have to take all of this into consideration. The dorsalis pedis artery is an option, but it's not recommended if the patient has peripheral artery disease or diabetes, again, due to that increased risk of complications. And the posterior tibial artery is an option, but it's not a good one. It's typically used as a last resort due to the greatest risk of occlusion and complications. So again, like I said, most of the time we're going to do radial artery or femoral artery catheterizations. Those are your most common, unless the patient has, a really strong contraindication not to use those. So I just wanted to show you, this is an example of the Allen test, and we use now a modified Allen's test, but it's traditionally performed before catheterization of the radial artery. So this is again helping us look for collateral ulnar arterial blood flow to avoid any sort of distal ischemic injury. So in order to perform the Allen's test, typically you want to feel for radial and ulnar pulses, and then we manually occlude those for about 10 to 15 seconds until there's blanching of the palm. So typically you're going to hold pressure on the radial and the ulnar arteries, and then you can look for the palm of the hand to turn kind of white. You can also have the patient kind of open and close their hand, and it should blanch. Then what you're going to do, the first thing is you're going to release your ulnar arterial occlusion and see what happens to blood flow. If the blanching resolves, there is patency of the ulnar artery, and that would indicate to you that it would be okay to use the radial artery in that hand because there's good blood flow with the ulnar artery open. If you do not have good blood flow and return of color, that's an indication that that radial artery, if that is occluded from an arterial line being placed in there, that the hand is not going to get adequate blood flow from the ulnar side, and it shouldn't be used. You should look for another site. Now, there are other ways to check collateral circulation depending on what site you're using, but this is really common for your radial artery, and it's something that should be assessed on every patient before you cannulate them. When we talk about benefits and indications for an arterial line, again, this is going to provide continuous access to arterial blood and blood pressure values for us. So when we have a patient that's on a vasoactive medication like epi, norepi, dobutamine, dopamine, etc., it's going to allow us to do that monitoring and titration in real time. And that's extremely helpful for us because it's giving us up-to-date, real-time blood pressure readings. And a lot of these vasoactive medications, I mean, they start working almost immediately, and then their half-life isn't very long. And so if you think about having a blood pressure cuff on your arm, and you're trying to titrate these blood pressure meds based on this, blood pressure cuff that's going off every 5, 10, 15 minutes or whatever, that isn't really the best way to do your titration. And if you're going to be running a vasoactive medication for an extended period of time, you really should be putting in an ART line and advocating that the docs put in an ART line for your patient so you can get the best accurate measure of that blood pressure, because you're titrating some pretty potent drugs here, and we want to make sure that we are titrating appropriately, because a lot of these medications, you're going up, you're bumping up these medications in really small amounts in order to get that MAP above 65. So we want to make sure that our blood pressure readings are accurate so we can titrate them appropriately. The other nice thing is if your patient is getting frequent ABG lab draws, this also is a patient comfort thing, so they don't have to get repeatedly poked in another artery somewhere. So it's nice that you have this kind of this system to be able to get this ABG lab draws done. Certainly if they need medications or fluids or something else, that you would need to advocate for a venous line. If you do not have a peripheral line, you cannot infuse anything through an arterial line. So if you needed to give meds or fluids, you'd have to have some sort of venous line for that. But if they are getting ABGs, it's nice that they don't have to get repeatedly poked. So that is an option. If you want to look at another video about just some other things that are important with arterial lines and some benefits, you can check out this video here down at the bottom of the screen. So we talked about indications for an arterial line. Let's look at some contraindications. So Again, we know that arterial line placement has risks and, very site-specific serious complications. So while these are not necessarily an all-inclusive list, these are some of your really big contraindications. So if the patient has peripheral or distal arterial insufficiency, so if they have peripheral artery disease, probably not a great idea to do this, especially in the lower extremities. If they have a lack of collateral circulation due to anatomical anomalies, such as say maybe your patient doesn't have an ulnar artery, or they had a musculoskeletal injury and that ulnar artery is damaged, something like that. If there is infection at the catheter insertion site, you certainly don't want to do that. You don't want to do it if there's burns over that site. If your patient is anticoagulated or in a hypercoagulable state, we know that the arterial line has an increased risk of clots in and of itself. So if they're already hypercoagulable, that's adding insult to injury, so we don't want to do that. But then certainly if patients are anticoagulated, this is a pretty invasive procedure. And so the inherent risks of bleeding, hematoma, bruising, and stuff are going to be higher. So you have to kind of, again, outweigh your benefits and risks. So hopefully this video will start playing for you, but I think this is really important to watch. This will run through setup of arterial lines, so it'll run through all of the equipment that you need. It'll also talk through how to zero the arterial line and how to just kind of get the system ready for a patient to be using it. So absolutely watch this video. I looked all over, and I found that this was probably one of the better ones from ICU Advantage. Just really simple explanations. I love it. Like I said, it'll walk through all the equipment that you need, how to set it up, the things that you can do ahead of time before insertion, and then how to get it zeroed so it's ready for patient use and patient monitoring. So definitely check this out. It's about a 10-minute video. All right, so hopefully you watched the video. Most of the equipment that you will need can be found in the central line kit cart. When you go into the cart, you will notice that there are central line packages kind of towards the bottom. But supplies that you want to make sure that you have would be sterile gloves and gown. That's typically going to be for the provider, unless you as the nurse are going to be assisting with insertion for some reason. Sometimes if it's radial, they'll ask you to hold the arm, in which case you would need to be sterile as well. If you're not going to be assisting with insertion, then you probably would not need sterile gloves and gown, but you would definitely need at least a clean pair of gloves, and especially if you're going to be handling any sort of equipment or getting supplies or whatever. You need sterile drapes, sterile towels, some gauze, chlorhexidine or some sort of iodine skin prep. You would need your 1% lidocaine without epi, and again, that's going to kind of be patient or physician specific what they're going to want for local anesthetic. Typically, they're going to do a 10 or 11 blade scalpel. They'll need a needle driver with some suture material, sterile dressing, and that'll be placed afterwards. As the nurse, it's really important that you get everything on the right side of the screen. A lot of the stuff on the left will be very physician specific, and they will probably grab these things themselves. And then, like I said, they'll pull it out of the central line kit. But as the nurse, it's important that you grab the pressure transducer kit, and that is like that line that looks like the IV tubing line that's got the transducer on it. You need your pressure tubing. You need your IV tubing with your connectors. You need an IV pole. You need the stopcock, which should be in the transducer kit. The doc will grab the appropriate size catheter for depending on what size artery you're going to go after with the guide wire. It might be good for you to grab the ultrasound machine. They should be palpating the artery as well, but oftentimes they'll use an ultrasound just for guidance. You also need the monitor cable system, which connects the arterial line to the actual vital signs machine. So you'll need that monitoring cable system, and then potentially extra staff, either to assist with placement, obtain supplies, provide sedation, monitor the patient, etc. So it might be a good idea to have extra staff around so you can do these things. But if you're going to be assisting with insertion or getting supplies, you will probably need to be sterile. just because if you're going to be handling things, all of these, instruments and equipment and stuff will be on a sterile field. So be prepared to be sterile if you're going to be assisting. Otherwise, it's a good idea to just have people in the room to provide some extra sets of hands, especially if you have to give some sedation medications and monitor the patient. All right, so before insertion, again, like I've said this already a couple of times, arterial line placement is really invasive. So the staff and the patient need to be prepared to perform the procedure to ensure ease of insertion and minimize risks. So staff should plan and ensure that all equipment is prepped using sterile technique and make sure it's ready for insertion. The last thing you want is the doc to be sterile and you need something and they have to break sterility and then go back into sterile technique to, if they're missing something. Staff should perform a timeout and complete all procedural documentation, especially if sedation is going to be used as well. And again, this is an invasive procedure. Typically, there should be consent that's signed. If it's an emergent thing, we assume that there's implied consent. But if possible, we should get consent either from the patient or family, and that should be signed ahead of time. And education about risks and benefits should be provided by the doctor, and the RN can witness that. Before catheterization, the doc should identify the vessel, and again, that should be on palpation and by use of ultrasound. The site should be prepped using antiseptic solution and allowing that drying time that's part of the sterilization and antiseptic process. And then you should place the sterile drape over the insertion site. All caregivers, again, performing insertion should be in sterile supplies, sterile gowns, gloves, masks. Typically, the doc is going to give the local anesthetic, and if the patient is stable, sedation should be considered just as ease of comfort for the patient. But then, of course, making sure you're monitoring them. So before insertion, on the nursing side of things, it's important that we gather our supplies like we talked about a couple slides ago. It's important that we get that 500 ml bag or that 1 liter bag of normal saline, and we prepare the solution, the flush solution first. So first and foremost, you want to get that bag and you need to prime and flush the transducer system. One of the most important things you need to do is ensure all air bubbles have been removed from the line, and that you remove all air from the flush bag. So as soon as you get that bag, spike it and burp it, or put in like a little catheter and get the air out of the flush bag. The last thing that we want to do is put any air into the arterial side of this patient. You could certainly stroke this patient out if they get a air embolism in there. So it's super important that you get air all the way out of the flush bag and the line in the system. You have to flush the entire system, including the stopcock, the transducer, and the pressure tubing. Once you flush all the caps, you have to replace them with the non-vented caps, and those come in the transducer pack when you open up the kit. Once you get your bag out and the air out of your saline bag, you have to put the pressure bag over the saline bag and inflate the pressure bag to 300 millimeters of mercury. And then you want to set the flow rate to about 1 to 2 mLs an hour. You want a little bit of a flow rate through your line, but you don't want anything that's, really fast or anything like that. You just want a little bit of counter pressure. You want to connect the pressure cable to the bedside monitor and then select the appropriate waveform label. So you want to make sure that whatever arterial site you're using, whether it be radial, femoral, or axillary, or whatever, you're choosing that on the monitor. First, you want to level the system, as she talked about in the video. You want to make sure that the transducer is at the level of the patient's phlebistatic access, which is that fourth intercostal space, mid-axillary line. You want to make sure that it's leveled. Any sort of fluctuation with the transducer, if it's up too high or down too low, it will affect your blood pressure readings. So it should be kept at the phlebistatic access, either on the IV pole or secured somehow next to the patient. Once it's leveled, you need to zero the system. And like she talked about in the video, you want to turn the stopcock off to the patient, open the little cap to air or to the atmospheric air, and then you want to zero the system on the monitor. So again, watch that video if that, if you need some extra help with that, but turn the stopcock off to the patient, open to the atmosphere, and then zero the system. So that is ready for you to set up when the doc is ready to do the insertion. So the line is ready to be hooked up and start monitoring the blood pressure. All right, so this is another great video. Hopefully it starts playing for you. It's from Emergency Management EM Core. So it's an emergency room nurse and doctor that walk you through kind of just the process of how to start an art line in the emergency room setting. It's fantastic on how to set it up. Again, kind of just going through all the supplies that you need, how to zero it, how to, get the system where it needs to be so it's ready for doctor insertion. All right, so ultimately the doc is responsible for insertion of the arterial line. However, the nurse can help with preparation, setup. You might be asked to hold an extremity while the doc is inserting, and then certainly it's the nurse's responsibility for ongoing monitoring after it's been inserted. But after the doc gets the catheter inserted, they're going to ask for the arterial line, and when you hand that to them, you need to make sure that there is liquid flowing through the line and that it's flushing with saline, so it just connects right away. You don't want any sort of risk for air getting in there, so make sure that you're handing that flushed line with liquid flowing when you give it to them. After insertion of the arterial line, the doc should secure the arterial line catheter, often with some suture material. They'll just kind of suture it in place. The doc and the nurse should apply some sort of transparent dressing for direct visualization of the insertion site. You want to assess for signs of bleeding, hematoma, bruising, infection, etc. If the wrist was used, you may need to immobilize the patient's arm or wrist or hand with an IV board, kind of like what we do with pediatric patients. You want to make sure that the transducer is in the correct phlebostatic access position to ensure accurate readings. You want to make sure that you're checking the monitor for a good arterial waveform, and that you're getting, decent arterial blood pressure in mean values, and there's another video coming up on what the waveform should look like. But using a backup method, just like a regular blood pressure cuff, will kind of get you in the ballpark. We don't want it to be too crazy different, but if the manual blood pressure cuff is somewhat close, you have an idea that your blood pressure monitoring, your arterial line is probably working for you, along with some other troubleshooting things that we'll look at. But it's important that you continue your assessment. We're checking for blood pressure accuracy. Again, this is comparing the arterial line with like a blood pressure cuff monitor, and we want to just make sure that there isn't a huge discrepancy there. The patient should also have frequent cardiac, neuro, and respiratory assessments, and then your neuro assessment should include CMS distal to the site of insertion, and we should always be checking for the 5 Ps: pain, pulses, pallor, paresthesia, and paralysis. And then we want to always monitor for any possible complications: pain, bruising, hematoma, infection, thrombus, fistula, air embolism, ischemic injury, etc. Any sort of complication needs to be, the doc needs to be notified ASAP. When we look at the arterial line waveform, again, a great video from ICU Advantage, check that out. She just goes in and talks about the waveform and, the different, what we should look at for normal values and what it might be if there is an issue with the line itself. So when we monitor a patient with an arterial line, typically it'll show up on our monitor in a red color, and it'll say like our ABP, which is like arterial blood pressure. It should say that on the monitor. When you look at the waveform itself, you can kind of see this, this little hill, and it's going to be measuring our blood pressure. So the systolic phase is when the heart contracts, the diacrotic notch reflects the closure of the aortic valve, and then the diastolic phase is the pressure going down in diastole. So it should kind of have this kind of rise up to the systolic. You're going to notice this aortic valve closure, which is the diacrotic notch, and then you should have this diastolic runoff, and then it should kind of go back to this shape again, and it should be pretty consistent. if you're seeing alterations in that waveform, we call that overdamping or underdamping. An overdamped waveform may be caused by issues with the tubing, loose connections, a blood clot, or maybe the cannula is kinked. So that can happen. And then an underdamped waveform where you're not getting those really prominent rises and falls, that can be caused by the tubing issues. So it could be too stiff, you might have too many stopcocks, or if you've got a defective transducer. So you really should have this very consistent waveform. And if you notice that your waveform is changing, you need to, 1, assess your patient, and then 2, start looking at your system. Start looking at your tubing, look at your connections, look at your transducer, make sure that has, that is stayed at a, level system area. You need to just kind of do some troubleshooting to make sure that all is working so you can continue to monitor your patient. All right, if you need to draw some blood from an art line, again, this is a great video. Kim Garza is a nurse and she explains how to do that within your system, and always follow your hospital's policies on this, on how they want you to do it. Some actually have a separate piece to the transducer system and the line where you can actually just draw blood straight out of there. You don't have to interrupt the system at all, which is kind of nice. We do not have that. But when you're drawing up blood and stuff, she goes through the method that we have currently at our facility here at Westfields. So when you're looking to draw up blood, follow this kind of procedure. It's just really important that you are wasting your blood because you don't want anything that's hemodiluted, and then you need to make sure that you always zero the system and flush with saline to kind of clear the tubing of any blood after you draw. The last thing you want to do is get any sort of clots, and you need to make sure that the system is zeroed so it can go back to accurate pressure monitoring. So check out this video. It's really short. She does a great job of explaining on how to do a blood draw. So lastly, if the doc indicates that you can remove an arterial line, you want to verify your order and remove it. Check the coagulation studies prior to removing it. The last thing you want to do is have some crazy coagulation or bleeding time studies, then you remove this thing and then it bleeds. You want to make sure that you keep the tip sterile when you remove it in case it needs to be cultured. And then as you remove it, you need to apply direct pressure to the site for at least 15 to 30 minutes. And then after that, you're going to apply a pressure dressing. And you always want to check for bleeding. And sometimes when they do these things radially, they actually have like these little bands that you can put on to kind of tamponade the area and just kind of put extra pressure on the area for bleeding. But if you don't have those, or if it's femoral or something, you're going to be in there giving direct pressure for at least 15 to 30 minutes, and then you're going to put a pressure dressing on afterwards. And then after you remove it, you always want to keep making sure that you are assessing ABCs, and then certainly going to be assessing neuro as well, those 5 Ps, even after you remove the line. Thanks for following along. This was a real quick overview of arterial lines. Hopefully you're able to watch the videos. They are super helpful. Next time you have a patient with an arterial line, hopefully you feel a little bit more comfortable with setting this up and using it, and then hopefully we can transfer them to a higher level of care as quickly as possible. But if you had to help set one up, hopefully you have a little more confidence in doing so. Don't forget that there are some great tip sheets in the RN skills binder. And, certainly go back and reference this. There's also fabulous resources on the Elsevier skills with videos and in My Learning as well. So check those out if you need some more resources.